Good morning, ladies and gentlemen. Thank you very much, Mr. Chairman, for the introduction. This morning, I will have a talk about the role of external counterposition in improving microvascularization and enhancing tissue perfusions. This is my outline. As well as you know that I think that microcirculation is very important, as well as you know that we just only know about the left main LED circumflex and right coronary arteries, but that's very important that we call arterioles and capillaries in our coronary arteries. I think that microvascular play a roles in the physiological regulations of myocardial perfusion. And then, of course, that the cardiovascular stress and present of coronary disease expose the dynamic nature of vascular-derived mediators. And then, of course, that these mediators will stimulate dilatation and vascular hemostasis, and then the impair of microvascularization, of course, that it will induce the hypoxia and ischemia and poor tissue perfusions in, of course, that it will make a cardiovascular event. External counterposition is one of the therapy that is a procedure that performed in patients with a refractory angina to relieve ischemia symptom, improve functional capacity, and enhance patient quality of life. This is a non-invasive medical therapy that can enhance venous return and coronary perfusions. How about the guideline? It is stated in the AEC guideline that enhanced external counterposition may be considered for symptom patients with debilitating angina refractory to optimal medical and revascularization strategy. Even though it's still in 2B or level evidence of B, I think it is clear stated in the guideline because this is the most promising and easy implementable in the every clinical practice. The most important thing that the external compensation has been shown to ameliorate refractory angina in several trials. In our countries, in Indonesia, Indonesian Heart Association endorsed ECP as a non-invasive option for refractory angina, adapting AC recommendation to Indonesian practice. How it's work? Actually, that we know about the diastolic inflation and systolic deflations. I think it's mistyped because we know with the diastolic inflations, it will be diastolic augmentation and increase the coronary proportions and increase venous return. Of course, it will increase the cardiac output, and systolic unloading, of course, that will reduce the cardiac workload, will reduce the systemic vascular resistance and increase the cardiac output. The main thing that is very important is a retrograde pressure wave that augments diastolic pressures. Diastolic augmentation is very important because it will increase the coronary perfusion pressures, enhance preload, and improve cardiac output. If you see here, what is the physiological effect of the external counterposition? I think in my centers, we try to looking more about the angiogenesis and arteriogenesis. I think ECP, there is a lot of trial, RCT, about improve the endothelial function, improve the, increase the coronary perfusion, decrease the angina for the patients in coronary artery disease. But I think the enhanced collateral capillaries, I think is very important in angiogenesis and arteriogenesis. How about the effect of ECP in the central and peripheral mechanism, as well as here is that you see centrally the ECP enhanced coronary perfusions and cardiac output, while peripherally it is increased endothelial stress with triggering vasodilation, angiogenesis, and anti-inflammatory effect by regulating endothelial mediators. How about the evidence-based clinical outcome in ACP? If you see here, this is a study that we made in our centers in Harapan Kita Hospital, National Cardiovascular Centers. We published it in our Frontier in Cardiovascular Medicine. The title is about the external counterposition that improve angiogenesis by preserving vascular endothelial growth factors A and vascular endothelial growth factor receptor 2. If you see here, this is the non-invasive treatment that we give to our patients with refractory angina. And then the result is very good. It's stated that it's promote angiogenesis by maintaining the expression of VEGF-R and VEGF-FR2, leading to the formation of collateral circulation and endothelial repair, as well as to know that improve endothelial function, of course, that will increase the nitric oxide and reduce the arterial stiffness. And then in a field of ECP and refractory angina, I think is established. This is a non-pharmacological treatment that we can perform to our patients with the refractory angina. Because the benefit of ECP is reduce angina frequency, improve cardiac function, enhance physical activity tolerance, like 6-minute walking test, improve quality of life, and of course that you will increase the angiogenesis of your patients. This is from the Reinhardt 2021. It is a meta-analysis and systematic review. It is stated that ECP treatment significantly reduce angina severity and improve exercise capacity and quality of life. CCS class, 6-minute walking distance, and then quality of life, of course, and then functional capacity will increase, and then of course that will reduce the angina score. This is a result that effective non-invasive therapy of refractory angina, especially in patients with ANOCA. And then you see the outcomes, walking distance, and then exercise treadmill tests significantly increase after treatment with ECP in refractory angina patients. And then this is a treatment ECP in ANOCA patients. If you see here, this is a population of 100 patients with ANOCA. We treat with ECP, and then you see here that it is reduced 50% of the CCS class. The CCS class improved in our patients, the patients, and then increase the 6-minute walking distance, the functional capacity and quality of life of patients with ANOCA. And then this is stated that in ANOCA, the coronary microvascular dysfunction, impaired vasodilation, will ECP restores endothelial nitric oxide activity through stress, improving microvascular flow and inflammation. And then ECP enhanced coronary microvascular perfusion, translating into significant symptomatic and functional improvement in ANOCA patients. This is in peripheral artery disease. If you see the graph that the ECP treatment significantly improve brachial FMD and quality of life, increase walking distance, increase blood flow, and diameters of the popliteal artery and posterior tibial artery. Of course, that this is a study from Tankar in 2010. It is stated that the PAD patient who stop ECP more often have higher rates of myocardial infarct, PCI, or heart failure through overall adverse event. After ECP therapy, patients with PAD show similar clinical function improvement, those are in the PAD patients. And then, of course, that in heart failure, I think it is established that, first of all, that ECP was safe and well tolerated and resulted in a reduction in pro-BNP level, BNP levels, and safe for the symptomatic heart failure patients without any adverse event. And then you see here that this will reduce the NT-proBNP. And then from the Excel trial 2025, we know that ECP significantly improved 6-minute walking distance, left ventricular ejection fraction, and NT-proBNP. And then the others trial meta-analysis, it is stated by Zhu in 2021, improving RCT with 800 subjects. It is clearly stated that ECP improved 6-minute walking distance, left ventricular ejection fraction, and then NT-proBNP. This is the case that we have in our hospital. Men 55 years old come to our hospital with progressive heart failure, functional class 2, with CAD post early PCI 1 days in LED. If you see patients come to us with a deep SNU on exertion of top new PNG and chest pain, 7 months before ECP, patient got a non-STEMI, and then we perform the early PCI to the patients. You see here is that there is cardiomegaly, and then we treat the patients with the dapagliflozin, SGLT2, ARNI, bisoprolol, spironolactone, rosuvastatin, aspirin, and clopidogrel. This is the result. If you see here is that pre-ECP, the left ventricular ejection is about 32%, and then after ECP, it increased to 19% with the increase in 6-minute walking test, and then reduce the NT-proBNP. I think this very give a good impact to our patients, and then the activity, the daily activity. The second case, you see that men 51 years old come to with the reduced exenfrations. We have a lot of patients with the reduced exenfration less than 30%. If you see here that they come with the 28%, and then we perform at the time primary PCI before, and then 8 years before ECP, the patient actually already have an STEMI, and then they have a primary PCI when there's LED. We give an ARNI to the patients, beta blockers, MAR, aspirin, statin, and then the glucose therapy. If you see here that from these patients, we give an ACP 35 times, and then the exenfration will increase from 28% to 35%. But I think the most important thing is that the functional capacity with the 6-minute walking distance increase from 365 to 453, and then it's reduced the NT-proBNP. As a take-home measures, I will stress that the ECP is safe, non-invasive therapy that enhance coronary perfusion and venous return through sequential valve inflation, improving myocardial oxygen supply. And then mechanistically, ECP improve microvascular by increasing endothelial stress, stimulating nitric oxide release, reducing inflammation, and promoting angiogenesis. Clinical evidence of a lot of clinical evidence support ECP in refractory angina and ANOCA, significantly reduce angina severity, improving exercise tolerance, and enhancing quality of life. Additional benefit, of course, are observed in heart failures and PAD, including improved ejection fraction, walking distance, and vascular function with acceptable safety profiles. And then the last is ECP complements optimal medical therapy and should be considered as part of integrated cardiovascular care of patients which is non-suitable for the revascularizations. I think that's all. Thank you very much.